So in the next 15 to 20 minutes, I'll briefly talk about where we've been. Although I'm pretty young, so my perspective may be a little slanted, but where we are now, and I guess most importantly, where do we need to go to improve end-of-life care in Canada? So where I'm coming from with all this is that I'm a clinician. I'm a doc that works in an acute care hospital in Hamilton. And I'm also a clinician researcher. And the focus of my research in the past 3 or 4 years has been almost exclusively on the issue of how can we improve communication and decision-making near the end of life for seriously ill hospitalized patients and their families. And the reason why I just wanted to put this up there is that I'm not firmly entrenched in the palliative care community, and so I may not be keenly aware of all the important work that's going on there. I'll speak mostly about what I'm most familiar with, so it's not an apology for what I'm going to present, but just to be aware that it's just a particular perspective that I'm sharing. So this is to quote Joanne Lynn, who's been a pioneer in end-of-life research in the United States. She says, over 100 years ago, people just got sick and died, and it was often in a matter of days or weeks. So this is George Washington at his death. And if you read the accounts of his death, he got sick on a Friday out in a field, and by Sunday morning he was dead. And not that long ago, this is kind of the way death was. It happened rather quickly, and you can also see here in a home setting, not in a hospital. So things have changed remarkably over the past 100 years, largely because of the advances in therapeutics, which have been very good things, but it's also changed the nature of how we die and the trajectory of dying. So whereas sudden death was accounted for a lot of dying trajectories in the past, now the dying process is much more prolonged. So about 2/3 of us these days are kind of in these bottom two boxes of dealing with progressive organ failure of the heart, the lungs, the kidneys, with maybe ups and downs in health, or a more prolonged state in frailty, such as with dementia. And so I think we're still coping with how to adjust our models of care and our approach to treatment given this new reality. So where have we been in Canada? Doris mentioned the International Palliative Care Congress. The modern palliative care movement, I guess, is widely regarded as having been started by Dame Cicely Saunders in the UK in the 1960s. And then 1 year after I was born was the opening of the hospice programs, or the palliative care programs, at St. Boniface Hospital in Winnipeg, and very shortly after Royal Victoria Hospital in Montreal. And that's when I guess the palliative care movement really was established in modern terms in Canada. And over the years, there's been much more organization of this movement with the Canadian Palliative Care Association, which is now the CHPCA, and with important national reports, position statements, including by Senator Carstairs, focusing on the needs for good end-of-life care for Canadians. But I guess my reflections, at least, are that a lot of palliative care in its earlier days in Canada was focused on end-of-life issues faced by patients with terminal cancer, and that it's been more recently that attention has been turned to not just patients with terminal cancer, but with many other life-limiting non-cancer diseases, which is typically, when I'm at the hospital, what I'm dealing with. And so to turn my attention now to some landmark research findings that have brought us to where we are today. The SUPPORT trial, certainly in 1995, it was published, was a landmark publication done out of the United States at multiple acute care hospitals, and really served to shine a light on, number one, the nature of dying in hospitals, and again, largely by people without cancer. So about 85% of these folks didn't have terminal cancer, but had some other form of organ failure. and documented some important gaps in the care of these elderly folks. Lack of alignment between what kind of treatment patients wanted and what care was actually prescribed, untreated pain near the end of death, physicians not being aware of patients' preferences near the end of life. And they actually rolled out a very sophisticated intervention that was designed to try to improve the way we communicate and make decisions with these folks. For a quotes negative trial that didn't have an impact on any of the outcomes they were trying to improve, such as aligning care with patient preferences, treating pain near the end of life, they got a lot of press for this negative trial. And really, I think, was a landmark trial for the way we look at scholarly work in end-of-life care internationally. And so what's been happening in Canada, just briefly, so there's been good support for end-of-life research in Canada. Although the CIHR committee structure is changing, there has been, for several years, a palliative end-of-life committee to support scholarly work. In the early 2000s, importantly, there was a specific funding envelope through emerging team grants that supported a number of different research programs and teams of researchers on a number of topics related to end-of-life care, including family caregiving, cancer-associated symptom treatment, vulnerable populations, as well as improving communication and decision-making at the end of life, which is, of course, a topic near and dear to my heart. And that latter bullet, a lot of that work was done by the Canadian researchers at End of Life Network, or CareNet, which, again, as John mentioned, was part of the origins of TVN and continues to kind of exist to this day, although without core operating support because of that net grant being a 5-year limited term. And what I'm going to describe to you now for the next few minutes are what were some of the important findings that came out of, in particular, the CareNet research group as it relates to communication and decision-making at the end of life. What have we learned in the past several years? So this is an important study by Darren Hyland, a colleague and collaborator of mine, in the Canadian Medical Association Journal in 2006, that went straight to patients and family members who were patients seriously ill in hospital, so a form of, I guess, patient engagement, if you could look at it that way, and asked directly to them using a survey administered face-to-face, what's important to you in defining quality end-of-life care? And the things they rated as extremely important were things like having trust and confidence in the doctor looking after you, not being kept alive on life support when there's little hope for meaningful recovery, receiving information about their disease in an honest manner, ultimately asking for good communication and decision-making around their care towards the end of life, which I guess also showed up in the dialysis patients' list of important things in terms of their research priorities. So patients and families are telling us this. They want good communication and decision-making. And in a follow-up study to that in 2010, where the same group of researchers looked at items that were important to patients and families, but they weren't all that satisfied with, again, issues related to communication and decision-making come up as high priorities. So if we're to improve end-of-life care in Canada, there are many things which I'll talk about towards the end of my presentation that we need to work on, but certainly communication and decision-making is one of those areas. So where are we now? So I'll spend a couple minutes talking about what the current landscape looks like, at least from my point of view. If you search PubMed for articles related to advanced care planning, there's been a substantial increase over the last 10 years. So now we're at almost sort of 5 papers of new knowledge being published every week in the medical literature about advanced care planning. And certainly this term has gotten, I think, a lot of attention and traction. And I guess at least in my view, seems to be replacing, or maybe not replacing, but complementing the idea of documents and living wills and advanced directives as the end-all and be-all of how we communicate our wishes, and emphasizing more on a communication process whereby an individual, like me or my wife or my mom or dad. Talk to the people who are most likely to make decisions for me when I'm sick. Because we know most people won't be able to speak for themselves when they become critically ill. And so the emphasis being on communication of values and preferences to those future substitutes. And that's what this schematic here is sort of our research group's way of conceptualizing end-of-life communication, decision-making in the broadest sense, and where do different things fit in. So advanced care planning being a more maybe upstream activity that occurs before you're really, really sick, but that can provide very helpful information for making in-the-moment decisions when you're acutely ill, for example, in a hospital, about the care that needs to be delivered, or so-called goals of care decisions in the moment. And of course, all of this is supported by good documentation practices. So there's been a lot of interest in improving communication decision-making and advanced care planning in particular. Has that made a difference so far on the Canadian landscape? And so here are some findings from a recent multi-hospital audit of advanced care planning practice in Canada, looking at what's the current quantity and quality of communication and decision-making around the end of life. So what it found, so these are patients at high risk of dying. These are not well hospitalized patients. What the audit found was, first of all, that most patients have thought about the kind of treatment they would want at the end of life, that many of these patients have, in fact, discussed their preferences with someone, and that most patients actually don't prefer a treatment plan that includes CPR. It's about 10 or 12%. But a concerning finding was that if you looked at the prescribed orders for care in the patient's charts, the goals of care were discordant with patient preferences most of the time. And so compared to the support trial from 20 years ago, we really haven't moved the needle much on aligning patients' treatment or prescribed goals of care with what their preferences actually are, which is a bit discouraging. So, me entering to this fairly new as a researcher and trying to, move the needle and make a difference, it is a little daunting to think about. In 20 years we haven't done a lot in terms of moving that. But I do think that, although I was just a kid at the time when the support trial was published, my sense is that there is a much different social context now than there was 20 or 30 years ago. For sure, there's a demographic change. We see a lot of coverage of end-of-life issues in the media, both good and bad, but there's a lot of awareness, I think, now, less of a taboo topic. And there's an enormous amount of policy attention in the past couple of years from decision makers, governments, major organizations. And so I think there is a much more readiness to hear about these issues and to study them and to try to improve things. So I'll end by talking for a few minutes about thoughts of where we need to go, or what other very smart people who are smarter than me have said about where we need to go. So almost exactly 2 years ago in Ottawa in 2012 in September, the Canadian Academy of Health Sciences led a forum on end-of-life care called The Last 100 Days. So a lot of our best and brightest scholars and medical researchers in Canada got together to think about these issues. Some of the findings of that conversation were published in the CMAJ in November of last year. And these were some of the key points in terms of where it was thought that we need to go with end-of-life care in Canada. One is to narrow the gaps between the end-of-life care that patients prefer and what they actually receive should be a national priority. So fixing that blue and red graph that I showed you a couple slides ago, that the quantity and quality of advanced care planning needs to be improved, that burdens to family caregivers who provide a lot of care must be acknowledged and addressed, and that physicians, and actually not just physicians, but clinicians in training, need more and better education about palliative care. Doris was talking about this recent declaration and now the survey to follow up I think that's going to be really important to understand how we give the skills to the people on the front lines that they're going to need. So that was the Canadian kind of perspective, and I think we were ahead of the Americans on this one. So just on the 17th of September, so not even a week ago, the Institute of Medicine, which is a very influential body, again, of very smart people, released a report called Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. So that's gotten a fair bit of press already. I haven't read the full report, it's very long, but there are some very notable experts on that panel. It was a nonpartisan committee that was tasked to provide recommendations about how to improve end-of-life care in America. And a lot of their recommendations touch on the same things that the Canadian group touched on a couple of years ago. Again, issues around improving communication and decision-making and advanced care planning, a real need for professional education and development around palliative care skills. I think it'll be very interesting to see what the survey that Doris talked about shows us, but my perception is that we can't possibly train enough palliative care physicians to look after all of the patients in Canada who are going to need palliative care. And so upskilling the workforce is going to be important going forward. Of course, there are issues around models of care and putting the right reimbursement structures in place to make us want to do the right thing. And also a need for public engagement and public education to change societal viewpoints. So I'll just end with, I'm going to skip these slides, kind of a summary of different areas at different levels where I think there needs to be some focused effort. So again, by all means not the only perspective, but my perspective. In terms of how can we best support patients and family members, certainly more patient engagement that Andreas talked about, but if you look at the work that CareNet has done to directly ask patients and families what they want, they're asking for better communication and decision-making. I think what we don't know now is there are many advanced care planning tools out there, but a recent systematic review has concluded that there's relatively much less evaluation. So what are the best tools to use in which settings and which context is still an open question. In terms of clinicians, I think the biggest needs are around training and supporting their ability to provide good end-of-life care, both those who are currently in practice as well as, in particular, those who are coming up through the different professional schools. For the health system, there's fairly good evidence out there about the benefits of integrating an early palliative approach for patients with cancer, without cancer. I think the challenge is in the delivery. How do we set up those models of care so that they're efficient and effective? And that's certainly a challenge. The other point I'd say about the health system is I work in a hospital area, and I think there's a lot of research activity going on in the hospital field, and there will need to be for some time. But what I've seen is a growing interest of doing research, and I think a huge opportunity to do research in other settings, including long-term care and community care like home care, where there's perhaps been less of a focus in terms of health services research. Finally, I think there is a need for social change, changing the culture. There's long been said that we live in a death-denying society, and I think I talked to some palliative care experts in Hamilton, and they talk about, a lot of other diseases or other organizations have sort of a public health arm. The lung guys have, smoking cessation, and cardiovascular folks talk about diet and nutrition. But in palliative care, there's kind of nothing. And the thought, I think, there is that the palliative care community or end-of-life research needs to also think about what's the public health kind of strategy? How do we engage communities and create a social movement that makes dying something more acceptable to talk about? And how do we bring communities together to provide care at the end of life, kind of outside of just the medical realm? So I think to improve end of life in Canada going forward, we're going to need a lot of different people with a lot of different skill sets to work in concert. I like this quote from two of our best and brightest medical researchers in the area of end of life care. Deborah Cook and Graham Rocker recently said, if we needed a cause to unite us all, improving end of life care should be that cause.